Good afternoon, good morning. Thanks very much for giving me the opportunity to close this wonderful 5th Pediatric Transplant Symposium and to talk to you about training in pediatric transplant surgery as one of the first pediatric transplant fellows, I would say, within Europe in such a position, which is also in my mind the best job in the world, thanks to many of you who are sitting in the audience, who I have the great pleasure of working with every day. A bit about my cultural background, for people who don't know me. I'm originally from Austria. I have trained there as a general and transplant surgeon for 5 years. And transplant in Austria is a little bit different because we do not have these numbers that we have in the UK. Because transplant is mainly with DBD donors, but also living donation is only allowed between first-degree relatives by ethics, which is why obviously these numbers are very, very low. So you do not get as much of an exposure to it as you get here in the UK. So when I came to the UK, my initial plan was to come to London, do my PhD, which I did at Imperial College, and then go back to my training. But during my time here in the UK, I got exposed to a lot of kidney transplant cases, and I learned that this is something that I want to do. And then I didn't want to leave after the 3 years, and I applied for my position at Guy's Hospital because I saw this is a center, they have the biggest numbers in Europe in kidney transplant, and one particular reason for me was to get exposure to pediatric kidney transplantation. So whenever I could back then as a trainee on the adult service, and by persuading the rota, the person who was responsible for the rota, whenever I could, I tried to get involved in one of the pediatric cases, which unfortunately was not, you didn't have the opportunity to follow up on them afterwards because you were still in a position where you were mainly focusing on adult transplantation. So when you look at the numbers in the UK, there is, at a certain time point, there were 93 pediatric patients on the waiting list for a kidney. And in between 2018 and 19, there were 139 pediatric kidney transplantations performed. And when you then see that between Great Ormond Street and Guy's/Evelina, 1/3 of all these cases were done in between these two centers, it makes sense that A, you get great exposure as a trainee in pediatric transplant surgery, and B, to create a position like that. So last year in October, this position started off with Muhammad, who started the fellowship as the first person and who did a great job and who handed it over to me. And when I learned about this opportunity, I was like absolutely keen. I need to get my hands in. I want to get involved because being involved in pediatric patients has always given me great pleasure. So just to give you a little bit of a background on what it means and who would be eligible to do so, I think, to do that position, to go into that position, I think it is a great opportunity to get some continuity and to not just get involved into the actual surgery, but also to get involved with the follow-up. You see the patients in outpatient clinics. You actually get to know what's happening with them, but not also post-transplant. Also for pre-transplant workup, it's very important. I did not have really much knowledge about what is important for a kid to get to that stage of actually being eligible for transplantation. So that's the main learning point, and you get great exposure between these two centers because of these numbers. And if anyone is interested to go into that position, I would say someone who is very senior in their training for general and transplant surgery, so that the actual operating doesn't play that much of a role anymore, but the actual management of the patient as a whole gets a bit more, is a bit more of a focus for that fellowship in terms of learning points. And then you also have to be a good communicator between teams, because for pediatric patient it's very important to have a multidisciplinary approach, as I've just mentioned, with urology before transplant, the colleagues from the nephrology department, obviously, in the whole management of the post-operative care, medications, medical complications, as we've all heard. So these are the 5 consultant transplant surgeons who, on a 1 in 5 weekly basis, so every week, one of these 5 would be in charge of the pediatric patients between our 2 centers, Evelina and Great Ormond Street Hospital. And my main job as a pediatric transplant fellow is to see all our patients or flag out problems to these 5, because they also have other commitments in the adult world that they have to take care of. So the main purpose of being in this fellowship is to, take care of the post-transplant patients, highlight problems, have the continuity of care for the actual patient, because there is no way, if you're between 2 centers, to always have everything in your mind that's going on with one of the patients at a time. And just to summarize, this is my schedule on a weekly basis. So you have pre-transplant clinics, you have access clinics, you have your dedicated lists, but you also have the chance to go and to attend a lot of multidisciplinary meetings, and that, I would say, is a big advantage to learn and to maximize your learning by just attending all these meetings, because you get so much information that you never were thinking about before. And the next thing is that at this stage, I really enjoyed in this position that you could also, around these fixed points, you could manage your own schedule a little bit and decide what to prioritize at a certain point when you get a call and someone calls you, oh, there is this sick kid, you need to, would it be possible for you to have a look? And then obviously you just prioritize, and that kind of gives you a training in the sense of it. I would say it prepares you a little bit for the life as a consultant surgeon, when it won't be any different in terms of having to prioritize what do I do first, and what do I highlight on the top of my list. So for my personal experience, I had a great experience. I started in April, and since then I was involved in 22 pediatric transplant cases. Out of 26 in total, so I missed 4, which I was very sad about. And out of these 22 transplant cases, 16 were extraperitoneal, bigger children, more than 20 kilograms of weight, and out of them 6 were small children, where we used an intraperitoneal approach. And the numbers in brackets are the ones that I was performing as the primary surgeon. So great experience there. I was involved in 2 very, very complex, interesting vascular cases, which again, that's exposure that I would say nowhere else, at least in Europe, you would get your hands into such cases, and was great learning points about just being there and just seeing what do you do if, and also with most of my consultant surgeon colleagues, you would go through the eventualities of a case before you actually start a case. So again, that's great learning to sit down and say, oh, So let's make a plan. What if we run into this problem? What if we run into that problem? So that's great learning on the surgical side. Then I was involved in 4 fistula cases. Again, they're very rarely done, with an aim to increase those numbers, as we have heard in previous talks. And then PD catheter insertions, which just come as emergency cases as needed. The on-calls are based at Guy's Hospital, and again, that gives you great opportunity to, besides being in a pediatric transplant position, to keep in touch with the state of the art in the adult transplant surgical world as well. So, as I've mentioned before, I've seen some very complex cases throughout the course of these past 7 months. So, on the left side, you see a picture that was taken intraoperatively for a case, one of these 2 vascular complex cases. So this was a kid with transplant renal artery stenosis of his solitary left kidney, and the plan was to give him a bypass jump graft from the aorta to his renal artery, with the backup plan of, if that hadn't worked, we would have probably opted for an auto transplant of that kidney. But fortunately it worked, and it was a really nice case. So he got a bypass graft from the aorta to his native kidney. That's the renal vein that's hiding the actual graft a little bit, but it was taken from his saphenous vein, and that was taken up to his kidney. Then, as Nikos has reported yesterday, this is a picture of the intra-abdominal situs of the parathyroid and kidney transplant, with the parathyroid gland marked here. And then another case that I've done with Professor Mahmoud of a kid with PUVs and big ureteric stumps that we had to remove when we were doing his transplant. And again, seeing these stumps intraoperatively, I've never seen anything like that before. So for me, that was again great learning, great experience to see something like that. So the main learning points for me were that, yes, children are definitely not small adults. Their underlying disease is completely different and more related to urological issues. So for me, to learn about all these abnormalities of the urinary tract and the workup, what to do before to make sure the bladder is safe, that was a completely new territory for me. Then the next thing was obviously the dosing of drugs, or also the expression of the urine output, everything per kilogram body weight. New territory for me. Now it's all fine, and I've learned how to do that. So again, communication is key. You have all the different teams. You have the psychosocial aspect for every kid. You need to communicate so everyone is on the same page before you go into transplantation. And some novel approaches that I have come across during my time was obviously the eculizumab as a drug where the numbers of PD catheter insertions went down because atypical HUS could be managed with eculizumab. The 3D printing, as we have seen, which is done by Pankaj to plan for complex cases. Then the local anesthetic management by inserting these catheters and make children leave their bed early after transplantation, which is a great approach to enhanced recovery. And then there is this book developed by Georgina Potier, who is a kidney transplant patient herself, which is an amazing book to show to children that prepares them for their transplant and for what to expect when they get transplanted. And then as a last, to continue from Peter's talk, I also started monitoring my heart rate during pediatric transplant surgeries because I thought it will be a great insight after my time as the fellow to compare all the cases that I've done and see how nervous or or excited did I get throughout certain cases, and compare it to a diary that I keep about how I perceived it in that situation. And besides all the hard work, we also have some fun in operating theaters. Always good, good mood and a lot of laughing as well, because obviously you need to keep a positive mind. And with that, I want to hand over to Zainab, who is going to continue this talk and talk to you about training from the medical point of view. Thank you.
I'm not going to have the really good pictures, actually. It's just going to be a bit boring now. Thank you very much. I'm just going to talk about the training in pediatric renal transplantation from the point of view of a nephrology trainee. As this slide was shown quite a few times yesterday and today as well, from the point of view of a trainee, you can see that of the 136 transplants, renal transplants done in the UK last year, 42 were done in London. And as a pediatric nephrology trainee, because we train in both centres, it's excellent news, because you get to be involved pre and post-transplant in the management of all these children. Not just it is the numbers of these children that are vast here in London, but also the surgical and medical challenges in transplanting these children. They're more complex surgically, like we heard yesterday and today, with absent vessels, HABOI and HLA incompatible transplants. We also have children with combined liver and kidney transplants who are waiting, and we are involved in their MDM discussions pre-transplant. And we now have an MMA collaborative network, which involves GOSH, Evelina, Guy's, and King's Hospital. And especially at GOSH, we have children who have heart, lung, and bone marrow transplants, and we're involved in post-transplant care where they're requiring renal replacement therapy post-transplant as well. So it's excellent exposure for us as nephrology trainees. Not just do children get transplanted for CACOD-related diseases in childhood, we have an excellent renal vascular service at Great Ormond Street, where it's very highly developed with fortnightly MDTs involving the nephrologists, IR, vascular and transplant teams sometimes, with 1 to 2 angioplasties per week. We get referrals from all over the country, but also from across the world. And this slide illustrates the number of meetings we had last year. There were 59 children discussed in 19 meetings last year. And as you can see, most of them were from UK, but some of them were across Europe, and one was actually from New Zealand as well. Of these 59 children, quite a few of them required a second, third, and a fourth meeting, which suggests how complex they were. And sometimes when angioplasties fail and we can't get the blood pressures under control or creatinines under control, there are autotransplants that also take place. In the last 2 weeks, we've had actually 2 children who've had autotransplants, and the youngest and the smallest one was done actually last week, who was a 13-kilo child, and Natalie mentioned this one as well, who had an aortic graft and a left kidney autotransplant, and who's actually doing quite well, and his blood pressure is actually quite better now. So it's not just me, as being an unbiased London trainee, saying that. It's actually the GMC survey from last year, between 2018-2019, puts GOSH and Evelina nephrology training as the top pediatric training for the rest of the London, so in the top 5 training places. And I have been given the feedback from GOSH team, which says that not only is it the volume and the complexity of the patients that everybody sees here, it's also the fact that we take personal effort in trying to cater to trainees' needs. We have lots of international trainees here who actually come, but we are trying to mold the rota so that they are involved in what they want to do and get out of their training. And it's done through a lot of hard work between the rota coordinator and everybody else, but also the junior lead, who's the consultant. So, in summary, without any pictures, we have world-class training in terms of nephrology, transplant, intervention, and immunology, with excellent exposure not only in volume but in variety and complexity. We have ample opportunity to get involved in really high-impact research, and everybody is quite open to that. And these are only some of the very few reasons why I think it's a very great place to come and train in. Thank you very much.
Any questions?
Well, first, thank you for Natalie and Zainab, because just focusing on London-based training, which is excellent. The first thing about the numbers is very important, because I've trained in different places, and you don't really get this much of exposure in other centers. I first started as a trainee in the Southwest, where and EWTD is a barrier actually to training, because I had to leave a message in the ward that every time a transplant happens, please call me wherever I am and whatever I'm doing. I think that initiative is important if you're training outside London. The second thing is about, I've had excellent mentors. I think Steve has been a mentor for a long time. The other thing about London is you learn more from the people here. So the CNS group, I think, are excellent teachers in themselves. So I've had the opportunity to work with, say, Maria or Jen or Sarah in Southampton, and now Crony and Evelina. So I think the psychosocial aspects and how to actually communicate with transplant patients, I think you learn more from them. So I think that makes London a very special place.
Yeah, I think sometimes we take these things for granted because there's so many happens all the time. But yes, excellent. Thank you.
Any other questions?
No, no question, just a comment. So my name's Claire, I work in the post-transplant team at Great Ormond Street, and I just want to say, actually, having the clinical, like having Natalie in her post, has made a real difference to our role, I'd say, in the post-transplant world, just talking for me. Obviously, Zainab's amazing too, but I would say that role has really helped kind of bridge that gap with communication and things.